Greetings, everyone. Kathleen Littleleaf here. Uh, Welcome to Suicide Prevention Basics. And I always like to add to that is that suicide prevention is not basic, but what this presentation includes is an overview, kind of a step-by-step on what might or would occur when we're encountering a client who may be suicidal or have suicidal ideations, and just kind of the processes of uh, what a typical organization might go through to acknowledging what an individual provider is responsible for. And so I'm going to go ahead and start from the beginning in the presentation and introduce myself a little bit. So my name is Kathleen Littleleaf, and I'm from the Blackfoot tribes in Alberta, Canada, and I have descendancy from the Blackfoot tribe in Browning, Montana. And I have worked within uh, social work profession as a counselor, therapist, currently a candidate, and working towards clinical license, but have been in the field for a number of years since 2005, and worked in a number of areas such as urban Indian health and in Missoula and in Billings. Worked in a mental health agency in Missoula, Montana. Worked in integrated behavioral health in Billings as well as in Missoula at Partnership Health Center. Worked in domestic violence and was a domestic violence advocate in at the YWCA in Missoula, Montana. And yeah, I've been able to gain some great experience, including working within the criminal justice system, whether it be from a professional working in a state approved program providing chemical dependency and mental health, or working in under research, working with inmates in the Missoula County Jail. And with that, I was able to provide some research and acknowledging Native American recidivism in Missoula County under the MacArthur Foundation. So that was a great opportunity and experience. So I work with older adults, younger adults, adolescents, children, and within a co-occurring capacity or strictly mental health or addictions. So yeah, so I'm really glad to be here with all of you and look forward to sharing uh, some important information and to continue to help in that professional development. So suicide prevention basics, and let's take a look. Being Native American, every time that we come together culturally, uh, we would come together and we would share something. And here, coming together is about acknowledging suicide prevention. And this would be an opportunity for my culture that we would say a prayer or do light some smudge, just a blessing for the entire presentation and everyone learning the same thing. So I'm going to go ahead. I'm not fluent in my language, so bear with me as I say the Blackfoot prayer. Ayo tsatatviyo, ispamoganan, nidake kimotsanan, nidake yi keki motsanan, nidake gsik motsanan, itspamos, itzi tabi minanaksi, ayo nidake tabi sitsanan. Iginapi, Idamapi, Ganai Ayogamatani, Swatsamani, not Beyotsan, A. Dear Creator, help us to love one another, to try hard in life, to respect ourselves, help our relatives to walk toward gentleness, happiness, and all that is good, to succeed in life for proper nurturing for long life. Amen. World Suicide Prevention Day, Poetry to Raise Awareness. So I like this because this just allows us to move into some important information and just to give acknowledgement to different movements or awareness that is made by, organizations or individuals across North America to acknowledging suicide. So here is a poem and a poem for World Suicide Prevention Day to raise awareness, but a poem to acknowledge the significance of suicide. The dark days, the immovable days, the days that feel like forever, the days wherein happiness isn't something you can remember. Know this weight will pass, and however long it takes, give yourself kindness, give yourself grace. So just a nice acknowledgement through um, poetry to acknowledge its significance, or uh, the impacts that suicide has on a community and nation. So here, suicide awareness, here's some statistics, and this is from the American Association of Suicidology. And this is just like a snapshot, a little bit of an overview of where we are per nation, and then narrowing it down to what we might be seeing in the state of Montana. Some of what we know, according to the American Association of Suicidology data for 2019. So fatal outcomes for men is 77.9%, and for women, 22.03%. So you can see some differences there. Definitely more so for men to complete suicide than for women, but at the same time, these ratios do change a lot, and they fluctuate, and you can see how the rate for completion of suicide for women has increased. One person every 11.1 minutes kills themselves. 3.6 male suicides for every female death by suicide. 26.1 rate of suicide of white men per 100,000 population. So that's pretty significant. 1.2 million suicide attempts using a ratio of 25 to 1. So that's very significant. 26 attempts every 26.6 seconds. And those numbers are pretty interesting too. 3 female attempts for every male attempt. So females are more likely, per statistics, to attempt suicide than males. As many as 40 to 50% of the population have been exposed to suicide in their lifetime. Increased alcohol use also increases the risk of violence, including homicide, suicide, sexual assault, and intimate partner violence. So looking at the impacts that substances has on suicidality. Social isolation, regardless of race, is a risk factor for suicidal ideation. So yes, isolation, the impacts of major depression, because there's a linkage to suicidality or suicidal ideation. Definitely something that we need to look at closer in regards to mental health. So mental health definitely is something that we need to be speaking more of, and understanding the significance of continuing to bring awareness and addressing any stigma about mental health issues overall. So here we're looking at what's happening in all races in regards to youth, and looking at Native American youth specifically, just because here in Montana, Native youth are more at risk for suicide. They have a high risk here in the state of Montana. So in Montana, according to CDC, suicide is the second leading cause of death among Native adolescents and young adults at a rate of 2.5 times higher than the national average. So rates of death by suicide among non-Native population peak in older adulthood, whereas rates of death by suicide among Native populations peak during adolescence and young adulthood. So here we're looking at these age groups 5 to 14 and 15 to 24 for both sexes, male and female, and both sexes of male and female for Native American. So for U.S. youth of all races, you can see the difference between the male and female, 0.7 and 0.3 for Native youth, both sexes, male and female, 3.6, and for male, 3.1 for female. So you can see there's definitely a higher rate. Looking at 15 to 24, both sexes, all races in the United States, 16.0 for males, 3.5 for females. For Native youth, both sexes, male, female, 58.7 for male and 20.2 for female. So definitely some scary numbers, I would say, very concerning. So looking at where COVID-19 has landed us, COVID-19 is some pandemic that is worldwide. As we all know, every one of us has been affected. And here, this is from the CDC, and they did a survey in June, not this past June, in June 2020, and they had implemented the survey to look at what is happening in regards to mental health and substance use. So we know per this survey that there was the concern, or there is the concern of suicidal ideation, contemplation of suicide, or actually committing suicide. But here we're looking at suicidal ideation. So for anxiety, depression, symptoms during COVID-19, this report identified that there was an increase due to COVID-19, that anxiety, depression symptoms did increase by 31%, started or increased substance use by 13%. So the possibilities, I mean, what this survey is saying to me is that because of COVID, we did see the increase of substance use. Maybe for coping, trauma, stressor related disorder symptoms increased by 26%, and seriously considered suicide 11%. So definitely a concerning report, and I'm just glad that the CDC did implement this report, because we know, or many of us knew, if you're looking at the trends per your organization, I know at this time, last year I was in Billings, and worked in integrated behavioral health for urban Indian health in Billings, and there was definitely a trend. Prior to COVID-19, our state-approved program in chemical dependency did see an increase. I mean, not to say an increase. We had stable numbers for those that were seeking treatment and referrals from criminal justice and CPS, things like that, steady numbers. But what happened when COVID-19 did impact and hit our communities, what I seen was a shift from those seeking treatment lowered compared to those seeking mental health. There was an increase. So the numbers did drop for those that were seeking treatment compared to the numbers increasing seeking mental health during COVID-19. So it was a really interesting thing to see at that time. So I think there was probably some different reasons why, for sure. If we look at COVID-19 and mental health, the increase of uncertainty, hopelessness, isolation, depending on the individual within their environment? Were they exposed to certain things already prior to COVID, such as domestic violence or any kind of abuse issues, or they had already had some mental health going in to COVID-19. So a lot of different factors. And I think too, a lot of community members were really hesitant to even go into clinics because of the disease factor of COVID-19, and it's easily transmitted or easier to the contagious portions of COVID. So I think a lot of factors, but definitely seeing that trend, the increase in mental health needs, and compared to those seeking treatment that lowered for chemical dependency. I'm sure that has probably changed now too, just because the trends do change over time. All right, so here is suicide prevention and the Three Sisters. So I'll talk about the Three Sisters in a moment, but first let's look at this. This is resources and recommendations for working with suicidal patients. So just kind of some steps of what we might, would encounter in kind of like a process and flow of what things might look like in your agency. Okay, so crisis intervention and response procedure. So when considering the type of resolution, staff should consider the following, and this is when you're encountering some type of suicidal or crisis. So if an emergency, we're going to follow the suicide assessment action plan. So what is your action plan for your agency, if you're from an agency? Or what is your suicide action plan for your processes in your own private practice? So here, this could reflect both of those things. So determining what your suicide assessment action plan is, first we're determining if this is a non-emergent situation or is this an emergent situation. So we do need to be able to acknowledge both sides of that, whether it's this crisis where we can implement some kind of crisis plan or safety plan, or do we need to go into the emergent and access immediate assistance. So identifying the type of crisis, developing the action plan, what's that going to look like? Attempt to diffuse the situation and reassure the individual and family. So we're always, from a helper perspective, we are providing that safeguard, we're providing that reassurance, we're providing that advocacy, we're providing that resource. So we're developing what that action plan is going to be and assisting to diffuse the situation or de-escalate. Once a situation is calm, and we can then determine what that resource is going to look like. What do we need to move into? Is this an emergent situation where we've identified that there is a risk, and being a suicide risk, that there is a plan? We've determined that the client that we've encountered is in that place where they are suicidal, because we've identified and we've asked those questions. Are you suicidal? They said yes, and then we move into identifying any kind of resources, being family, who can we call, someone to come and assist and be with the client. And if they can identify, we still have that responsibility to keep them safe. And so then we're moving into the place of accessing immediate medical assistance. So that being 911, or depending on your policies, are you able to transfer this client to the emergency? Is this a call where you need to have police assistance, ambulance assistance? So this is where we're determining, but whatever the decision is on who to call per 911 and so forth, transporting the client, you are getting them safe. So we've identified the crisis, and we've identified a suicidal client. We've accessed the assistance. We've called 911. Client is now receiving emergency services, emergency psych evaluation per 911, and now we move into making sure that when we're given that client that resource and that assistance and that help now, then we can make sure that what's the follow-up. So making sure that the client knows that they can come in the very next day, or they can, here's your card, they're gonna call you, or you're just going to place a tentative appointment for the next day. Even if they don't show up, they have an appointment, whatever that might be. So then we move into the documentation. We're documenting events to the extent possible and maintaining confidentiality. And the when required means, we definitely are mandated reporters, so we would breach that confidentiality when we definitely know a client is suicidal and we're accessing assistance for them. Maintain professional skills and resources, so definitely documentation, and then maintaining everything that we need to do for that documenting. So what's your policy to supervisor? What's the designated forms and reports that you need to fill for this situation? And then making sure that we do have those resources for clients. So maintaining your professional skills and making sure that you have updated resources. So whether it's, we have that follow appointment with the client, and then what are some other resources? Because we're identifying what the situation, what brought on, what were the factors in a suicidal ideation, and connecting the services or linking to resources. Identifying and identify post information about available resources. So here, client does he's stabilized or she's stabilized, and leaves the emergency services, comes back to your office, and then you're making sure that you have those available community resources if you're going to be linking to services. Keep all community resource information updated and seek additional opportunities when available to empower individuals or families. So always using that strength perspective. So here, this is a nice handout, and so this will be available. But this handout acknowledges level of urgency, level of severity, presentation, typical presentation and management. And so it's broken down from non-urgent to semi-urgent to urgent to emergent and immediate. And so this is just a nice little flow chart to have, because for sure when we're in that moment with our clients, they're heightened, they're in this emotional heightened place. And so we would also be heightened too, because we are triggered through our central nervous system. So for our central nervous system, we're heightened because this is an emergent situation. And so our stress hormones are activated. And so sometimes if we have this form or this handout on our wall, even, it's just something to have. Or, just to have some of the knowledge of where these areas might be for what we're experiencing with our client, whether it's on your desk or on your wall or in some policy and procedure manual. All right, so if we look at, I'm not going to go through all of this, but non-urgent. So here, the level of severity, non-urgent, how we know that? Well, there's no acute emotional distress or behavioral disturbances. Typical presentation, client's cooperative, communicative, able to give information, able to discuss concerns, follows instructions, and what's the supervision like? General observation, action, provide support, offer appointment help, additional community resources and connections. So the typical presentation definitely helps us for sure. I mean, all of it is very, very, very helpful. Let's look at semi-urgent. Semi-urgent, level of severity, moderate emotional distress or behavioral disturbances. Here, typical presentation, no agitation, restlessness, irritable without aggression, cooperative, gives coherent information, pre-existing mental health needs, symptoms of anxiety or depression without suicidal ideation, waiting, willing to wait for help. So supervision, internal observation, and intermittent observation. Action, consult with mental health professionals if available, connect individual with mental health services, re-triage of evidence increasing behavioral disturbances, intoxication by alcohol and other drugs as they may be escalate behavior. So it gives us a nice guide in what we might be running into per client. There's some mental health issues already. Might be running into a client who is intoxicated, and I know that there's a lot of other policies that will be within your agency around that too. Here, looking at urgent within 30 minutes, possible danger to self or others. So here is where we're seeing agitation, we're seeing confusion, intrusive behavior, ambivalence about treatment, and then so on. So here we might definitely be seeing some suicidal ideation. So here, supervision, close observation and support, alert mental health professionals if available, alert 911 if mental health professional is unavailable, maintain safe environment, triage, re-triage, evidence of increasing behavioral disturbances. So here we're looking at what's happening within 30 minutes. So this becomes very urgent. And the emergent, what's happening within 10 minutes. So with each one of those, as you see an urgent, emergent, and immediate, we are alerting 911. We are alerting, we're now in that place where we do have to breach confidentiality and we do need to access help and support for this client. So this is a nice form to have and a nice form to have. Sorry. Okay. And I think too, it's a nice layout, and even if you needed to adjust it for your organization, that's really fine too. Make it your own. Asking about suicide and what to do. So here, this is definitely difficult, and I knew this as a new professional back coming into the field back in 2005. It was really, really difficult to ask about suicide for me. And so I could only guess that it's, as a new professional, you know, when we're dealing with this life and death situation, it is hard. So I think back then, I'm not really sure. I'm thinking as a new professional student coming into the field, maybe I'm just trying to go back to see why I may not have really looked at this and really used my supervision to talk about, you know, being able to ask directly about suicide, because I didn't in my very first encounter with a client who was suicidal. They did have a plan. I didn't ask them if they were suicidal. What I asked them was, are you thinking about harming yourself? And they said, yes, I'm going to kill myself. Yeah. And so later on, I mean, this situation implemented this suicide action plan and things like that. One of the things before I go on, going back, when you are in that crisis situation, client, you've determined that they're not suicidal, we definitely, and they're in that place of ideation, we still want to make sure that we're assisting, we're addressing that ideation through their treatment plan. But here, moving into, a lot of agencies already have a treatment plan, but the crisis plan. What's the crisis plan? And then doing the non-harm agreement um, and signature. So that would definitely be of assistance for those that don't have that action plan, are suicidal, but maybe your agency already has treatment plan, crisis plan, and the non-harm agreement. That might be really, really helpful just to have those three up front in the beginning when encountering a client for the first time, or after the assessment, doing a treatment plan. That may be helpful. But definitely using your suicide action plan, I'm sorry, your safety plan or your crisis plan and a non-harm agreement. So I wanted to say that before I went on. So here we being able to acknowledge directly to the client, are you suicidal, to be able to ask those questions, not easy. And I know for myself in the beginning, I asked the client, are you thinking of harming yourself? I couldn't say it, I couldn't verbalize it. So for me, I had to go back and really assess why, why was that so hard? And there was definitely reasons why. And just to share, I have experienced suicide in my family, and I think that was one of the things. So being able to go back and know as a professional that we need to, get that assistance that we need, but processing it was definitely helpful afterwards. And we did get the client, I was able to assist the client getting safe, but being direct. So after learning from that experience and moving forward, being direct, using direct language. Are you suicidal? Are you thinking of killing yourself? Do you have a plan for suicide? Have you ever thought about suicide before, tried to harm yourself? Do you know when or a time when you would do it? So asking those questions, if they're suicidal, what are they thinking? What's their means? What's their access? What are they planning on doing? Is it taking pills? I mean, I've had clients tell me, I'm driving to this bridge, they named the bridge, and I'm going to jump off the bridge. I've already been there a few times before and contemplated it. And my questions were, where is this bridge? What's the name of this bridge? When was the last time you were at this bridge? So asking those questions, exploring. Do you know when or a time you did it? Do you have access to what would you use or do? So you're exploring that with your client. So what to do? So gaining information, asking direct questions. There may be situations where a client isn't interested in seeking professional help. But when they are suicidal and they said that they are going to kill themselves, they gave you the means, they gave you the plan, then we have to breach that confidentiality, and we do have to get that immediate assistance because we have that ethical and legal responsibility and being mandated reporters when a client is actively suicidal. So what you do, offer hope. We're there as a resource, we're there as support. We want to, we're continuing, building that rapport. We're engaging, offering hope, tell someone no secrets, give them that door, give them the verbiage that they're probably not used to hearing, or because maybe they haven't talked to anybody about this. No secrets. Don't leave them alone, take them to the ER, call 911. Lock up guns and pills. So this is also helpful for those that are community members too. What can a community member do? What can a family member do? Confidentiality, limited confidentiality reflected in these scenarios. So we do have a duty to warn of violent behaviors. Suicide, homicide, self-injury behaviors, imminent risk of serious bodily harm or death. We have that duty to report. Mandated reporting of suspected abuse, neglect, child, elder, individuals with development disorders. So we have that duty to warn. Mandated reporters. Within these scenarios is confidentiality, limited confidentiality, which permits individuals to share limited health information to ensure the safety and well-being of individuals. So we are breaching that confidentiality in these scenarios. We have to, but it is limited. So who are we sharing this information with? We're sharing it when we're connecting that client to healthcare professionals to address the danger, the lethality. That's when we're breaching that confidentiality. Because otherwise we're maintaining confidentiality and maintaining privacy rules. So those would be the only times that would be breaching confidentiality. Prior suicide attempt or attempt history. So these are some risk factors. Depression or other mental health disorder, substance use disorder, family history of mental health or substance use disorder, family history of suicide, family violence, including physical or sexual abuse, access to guns or other firearms at home, being in prison or jail, being exposed to other suicidal behavior, medical illness, ages between 15 and 24 or 60, trauma history. So these are some risk factors. Definitely, we might be able to include more, but these are some major ones. Something that we're definitely seeing within our statistics, within research, but as well as what we're seeing within our profession. Warning signs, talking about wanting to die, talking about having no reason to live, feeling hopeless, helpless, withdrawing from family and friends, talking about being a burden to others, changing eating or sleeping, too much or too little, anger, irritability, taking risks that could lead to death, such as reckless driving, expressing thoughts of death, deterioration in hygiene, noticeable mood swings from extreme anger to calm and happy, giving away possessions, saying goodbye to friends or family, putting affairs in order, making a will, self-injury or harming behaviors, family history of suicide, exposure to family violence, abuse, access to guns or other firearms in the home, being exposed to other suicidal behaviors, so that exposure. So that's one of the things for sure is in regards to suicidal ideation and completion of suicide. It's very impactful to those that they leave behind. And I know for sure we do need to have more discussions too about those those survivors of suicide. It's definitely impactful, but as well as how triggering it can be as well. Suicidal clusters in rural areas. If we talk about Montana, we know in regards to Native Americans, reservations are very isolated and rural. And what we have seen historically is that when there is one suicide on the reservation, we're going to see more. So when it comes to reservations, the impacts definitely is to family, but it's also to community. Reservations are very tight-knit, very close, but we definitely see those suicidal clusters on those reservations. But I want to acknowledge too in rural areas across Montana, because Montana overall is rural. Medical illness, bullying, and trauma history. So looking at major depression, trauma from a mental health perspective is something that we should always consider when looking at working with someone who has had that history or has that diagnosis. Survivors. So according to the Center for Disease, survivors that experience suicide continue this ongoing experience of ongoing pain and suffering, complicated grief, stigma, depression, anxiety, PTSD, increased risk of suicidal ideation and suicide, and like I was saying, less discussed but no less important are the financial and occupational effects on those left behind. So financial, occupational, but definitely spiritual, definitely mental, psychological. So here, like I had acknowledged prior, is that when we're in that moment with our client who's in this fight or flight place, when they've identified that they are suicidal, that they do have a plan, and we move into suicide action plan, suicide prevention action plan, we are heightened just as much as they are, and that's through our central nervous system. So here we're looking at the autonomic nervous system, we're looking at the sympathetic and parasympathetic nervous system. So we know the sympathetic prepares for action, parasympathetic prepares for rest. So, you know, there's a lot that's happening at that moment when you're with the client who's suicidal, because you have to be the professional and you have to be able to implement this plan and process of getting them safe. And so there is, you know, a heightened adrenaline that's going on. So we're going to see an increase in the sympathetic, increased breathing rate, heart rate, pupils dilate, sweating, stress hormones increase, digestion, saliva goes down. So being able to kick in the parasympathetic is important. So being able to interject in your central nervous system by take a deep breath, ground yourself, you know, touch your desk, you know, lean on it, lean into your feet on the floor, you know, get grounded, just de-escalate, drink some water, just because it's a stressful thing. We do get moved into that fight or flight. We do get moved into the survival brain. So survival brain, instinctual, and we don't have any control over that. It's like fight, flight, or freeze. It's unconscious. Just move into that place. Anything that's going to heighten our emotions. And, you know, so moving from survival to the limbic, that emotional, and it's very emotional. We're talking about suicide. It's emotional. So here, the brain is kicking in from that survivor to the limbic. It's emotional. Feelings, and then we move into the prefrontal cortex where we're integrating input and thinking from all those parts. But one thing happens after the other where we can finally get into, I was hoping it all show together, but where we can work all three parts together. So that's where the stabilization, like our own stabilization, ground yourself and know and have that confidence, you know, not being overly confident, but, you know, be confident, you know, that, you know, not that you've gone through, you've thought about these things, you've processed, you've learned, you've been through some education about these things, you've talked about it, you've taken, you know, classes or, you know, but, you know, just know you've done your research, you know, knowing your policies and procedures, knowing what your agency's suicide action plan is, knowing, you know, that you're going to go through these motions and making sure, because under all of that, for sure, it's that liability. We want to make sure that we're managing the situation because of that liability piece. But through all of that and everything that's been shared here, you would be moving forward and making sure that for your agency, your supervision, your professional development, all your QPR trainings, you know, that it's okay. You know, you're a helper, you're helping in this situation. And that's what we need in our world is more helpers. So, but resilience zone, getting ourselves back into some stabilization. So here we have, so the resilience zone is just, you know, stabilization. We're getting some resiliency. Here's the stressor and puts us in this, you know, that place of heightened heightened physiological stress hormones, survivor brain activated, and this would be really helpful for clients too. But here we're moving, and this is from the Trauma Resource Institute. So here we're looking at trigger happening, we're out of our resilience zone and put in this place of edgy, irritable, manic, anxious. And a lot of the time, if our resilience zone is really narrow, and resilience zone is just that place where our coping is, where we can bring ourselves back into some, de-stress, take a breath. A lot of times our resilience zone is so narrow that we'll be in high zone and drop into low zone, isolation, exhaustion, non-disconnected. But here is just this being a nice slide to really acknowledge what happens when we are in a high stress situation, and the importance of getting ourselves back into resilience zone. Okay, so I'm just going to kind of go with the flow. Get ourselves back into resilience zone. Okay. So, suicide prevention on a holistic model. Here, looking at individual, family, community, and nation. This is like a nice systemic model too, because we're looking at the different areas and how the interdependence of one comes together and affects everything. But here, we're looking at individual and addressing suicide prevention. So, from an individual perspective, what can we do more about suicide prevention, and really taking it in and knowing that it is within our community, and I can be a helper, whether it be from a professional to a family member to a community member wanting to make a difference or bring awareness, or just do some work around this, around suicide prevention. Identity building, so it goes back to the self, working out our own professional development, or like I had said in the beginning, I didn't ask that client directly that first time, and it bugged me because I was like, why can I say it? So I had to do some work around that, and now from that point on, I ask directly, and it's okay. Ask directly. It's so important. Self-advocacy, self-esteem, prevention through education, addressing the stigma, addiction treatment, mental health therapy, domestic violence treatment. So these areas definitely can assist in addressing suicide. Family, what can I do? Family supports, respite, parenting classes, acknowledging our own self-care, who's my helpers, who can I go to, attend survivor programs, especially those that have lost a loved one to suicide or a friend, address the grief and loss. So again, moving into our own healing, attending a group, family cultural programming. That's always good too, especially from a Native American perspective, acknowledging the high suicide in Montana for youth. That's definitely an area to help connect and learn more about the culture, which is helpful because there's a lot of healing in the culture. Trauma-informed agencies in school and community. Yes, becoming trauma-informed is very, 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 very important for any agency or individual practice, just because it helps us to be more aware of our own self and how we can possibly affect others without realizing that we're affecting others, through our verbal or our eye contact, or just, so it's just really, really nice area to explore and implement into your practice or agency. Special suicide educational programs, and its development, annual resource development initiatives to assist suicide prevention and suicide awareness. Definitely need funding in these program development. Reentry programs, initiatives to address mental illness, stigma, regular therapists, in the nation area, regular therapist, medical provider, QPR, suicide prevention trainings. So like I said, being able to continue to learn this on a yearly basis is very helpful when you're actually dealing with a suicidal client. Very, very important that we're doing these things, professional development regularly. Resource development, policy procedure development to include suicide prevention. What's in your policies and procedures? Does it include suicide prevention? If it doesn't, this would be something important to implement. Evidence-based interventions and best practice, culturally inclusive. So definitely continuing to implement your evidence-based interventions and best practice interventions, which is culturally inclusive and best practice. Cultural awareness trainings, definitely, especially talking about, again, Montana, for my area, for sure, Native youth being high risk. But overall, this is the minority in this state, but maybe in your state. So cultural awareness trainings overall is just very, very important. Healer, heal thyself. So here again, looking in and really acknowledging that professional development and addressing anything that we need to. I'm a survivor of suicide, and I know the lasting impacts that suicide has on someone and a family. And, grief groups is really, really good. Just that support system is really, really good. But yeah, it's very, very concerning, and it's very, very life-changing. So yes, so this topic is important from an individual community person who's gone through suicide, but as well as from a professional person who has encountered many clients who have been suicidal, and being able to really embrace that in an understanding kind of way that it is our responsibility to do the best that we can to address and work to help heal our communities. So suicide awareness. If you're in crisis and want help, here's some suicide prevention lifeline. And now we have the text Montana, which is really, really good. So here's some references, and sorry, I'm going to go back here. References, you'll have this slide and the handouts that I described in this presentation. And if there's any questions, I know through Montana Social Scientists, they're going to have an opportunity to be able to ask those questions, and we'll be able to share that with you, some answers with you, so we can definitely engage. So thank you for having me. This was great. Thank you for all the work that you do. It's so much appreciated and so needed. So have a good rest of your day, and hopefully we'll see you in some of our other upcoming trainings.